Hello, good afternoon and welcome to this next in the series of Royal College of Pathologists Guideline Implementation webinars. My name is Peter Johnston. I'm the Chair of the Scotland Regional Council in the College. Today I'm very pleased to be introducing to you the webinar where we have leading experts from around the country talking to us about the new tissue pathways for gynaecological pathology. They'll be clarifying some of the elements of the guidelines that may be of difficulty for people and help with the implementation on a daily basis. So we're looking towards practicality and common sense and the approach that we need to take to do these things correctly. I'm very pleased to introduce you to today's panel of speakers. They are authors of the tissue pathways, and there's more authors than there are on today's list. But today we have with us Professor Raji Ganesan, Dr. Bruce Tanchel, Dr. Jason Wong, Dr. Rupali Arora, and Dr. Pinias Mukonoweshuro. And so all of these people are going to be here. Some of them are going to present, and the rest will be participating in the question and answer session. Just to let you know before we start, the question and answer session will be about, the presentation will be about 15 minutes long, followed by a question and answer session, which will last about 20 minutes. All the participants will be muted, and so if you would like to submit your questions, please, on the Q&A button of Zoom, we will pick up those and try and answer them all, although with such a large audience, this may be a challenge. So we may have to come back to you later with answers if that's necessary. So without any further ado, I'd like to start the presentation by welcoming our speakers. First of all, Professor Raji Ganesan.
Thank you, Peter.
Thank you.
So these are the tissue pathways for gynecological pathology. It is the 2023 edition, the previous edition having been in 2015. We had a large number of authors because we wanted to share it amongst people who did their gynecological histopathology in different forms so that we could have a very unified version of it. And here is the list of authors. Today, we are going to share the parts of the pathway that we feel are most often used in daily practice. So I'm going to be talking about, I'm going to be talking about the general components of the guideline. The one thing we are quite proud of is because we've made the guideline a lot slimmer, and we are very aware that people are very, very busy with their work. So we didn't want a very, very big guideline. But the guideline covers generic issues relating to staffing, workload, and facilities, general principles of specimen submission, how to deal with biopsies, how to embed tissue, etc., and then going on to the individual organs and tissues. I'm going to be talking about endometrial samples and about uterus and about myomectomies. So with endometrial samples, which are probably one of the most often received samples in gynecological pathology, we ask you to consider template reporting. Now, the template reporting is there as an appendix in this guideline, and it's based on the two publications, that the Canadian consensus-based and evidence-based guidelines for benign endometrial pathology reporting, and another more recent article where it has been shown that this concise reporting is an acceptable alternative to descriptive reporting. One of the important things is what we call a non-diagnostic versus a diagnostic sample. So we only call those specimens which have no endometrial tissue in them as non-diagnostic or inadequate. Even if they have scanty amounts of tissue, we want to call them as adequate, but express in the report that this tissue is scanty or superficial, architecture cannot be assessed, etc. Because many of the women who actually come for endometrial biopsy sampling have got normal or atrophic endometria, which do not yield much material. And calling that an inadequate sample gets them to come back again for a test, which was not going to be much different because they do have atrophic endometria. Going on to the uterus, uteruses are handled in different ways, but we sort of accept all different types of handling as long as one can orient the specimen and deal with prophylactic hysterectomies and with morcellated specimens. With morcellated specimens, we advocate insertion of a dye by the clinician, but we all know in real practice, we don't see that. So careful examination of the morcellated specimen to try and find the mucosal surfaces of the endometrium and the cervix is important. Prophylactic hysterectomies, we make it a point to say every bit of the endometrium, including the cornua, need to be examined. We talk a little bit about block selection and report content and how to report morcellated specimens. It's my pleasure now to hand over to Dr. Jason Wong to talk through the rest of this presentation.
Yes, first of all, the ovaries. There have been minimal changes to the section on the ovaries, but and fallopian tubes as well, but hopefully it may reduce your workload. First of all, block selection for ovarian tumors. In the previous guidelines, it said 1 block per centimeter for tumors under 10 centimeters and 2 per centimeter for tumors more than 10 centimeters. However, the tissue pathway applies to benign lesions. I think in benign lesions, 1 block per centimeter is enough. And even for frankly malignant tumors, 1 block per centimeter is usually enough. It's really the borderline tumors, particularly the mucinous borderline tumors, which are often heterogeneous, where it's recommended you take 2 blocks per centimeter for tumors larger than 10 centimeters. And even for serous borderline tumors, some authorities recommend 2 blocks per centimeter for larger tumors, particularly those with a micropapillary cribriform pattern or microinvasion. So moving on to the fallopian tubes, again, there have been minimal changes here. The only one I could find was in 2015, they recommended sampling the entire fimbrial end of every fallopian tube, no matter what, but assuming it was present in specimen, no matter what the reason for taking it out was. In the latest guidelines, it encourages sampling the fimbrial end with or without a transverse section. So it's no longer mandated. And I presume that's because the risk of finding incidental stick in a patient with no risk factors whatsoever is extremely small. In the latest study I saw by Christopher Crum said the risk is about 1 in 900. So the risk is small, but also the benefit, if you do find stick, is significant for those patients, and the extra work involved for the laboratory, for the people cutting up, it is really quite minimal. It'll be interesting to know if people continue to sample the entire fimbrial ends of tube. I know that I do, but I'd be interested to hear from the rest of the panel. And the CFIM protocol for sampling the risk-reducing salpingo oophorectomies wasn't actually in the previous tissue pathway. There has been in the data set for now being brought into the tissue pathway. So moving on to products of conception, just a few minor changes. First of all, if you send things, specimens off to a supraregional trophoblastic disease unit, it sort of spells out for you that you should not discard the wet specimen until you've received the specialist opinion back, which is good practice no matter what sample you're sending off for a specialist opinion. They've also given a warning that it's unlikely that the material will be returned in exceptional circumstances. I had a beautiful example recently, which I failed to photograph before sending it off, and I'm having trouble getting it back for teaching purposes. So just bear that in mind. And finally, the other change is that the section on immunohistochemistry has been expanded, but it's no longer in the main text. It's now been moved into its own appendix. There's more detail about the use of P57, including detail about the internal positive and negative controls you should be looking for. And there's a very helpful table to chemistry in trophoblastic tumors and trophoblastic tumor-like lesions, which summarizes the findings which are only given in text in the previous edition. So that's it from me. So moving on to Bruce Tanchel to talk about the cervix.
Thank you, Jason. So in the cervix, there have been a bit more definition of various factors to help you with your reporting. So adequate is better explained, and it comes in line with what the screening program have said. So an adequate biopsy needs to include transformation zone, be more than 2 millimeters in size. It must be intact so you can actually make a diagnosis, and well orientated and well stained, and not contain an abnormal, and an adequate one will always contain an abnormality. Sorry, there's a mistake there. Next slide, please, Raji. Inadequate cases will not fulfill the criteria for adequacy. And if you're looking for a squamous lesion, you need to see squamous epithelium and no abnormality. And if you're looking for a glandular lesion, you need to see glandular epithelium and no evidence of an abnormality if you're going to call it inadequate. Next slide. We've been a bit more prescriptive or a bit more descriptive on what levels we expect for things. So 3 levels should be adequate for a cervical biopsy. But if you're still not happy with the 3 levels and you see things you want to investigate, you may do some more levels. In loop and cone biopsies, only 1 full face of the section should be fine for diagnostic purposes. But again, if there are some features that you may want to further investigate, then do levels, but don't do three levels up front on loops and cone biopsies. And if there is missing surface epithelium or squamous junction or discrepancy between histology and cytology, usually a single further level is adequate. Next slide. There's been a bit of a change in the guidance, colposcopic guidance for patients with over age 50 years or over. So if you have CIN3 as your deep or lateral endocervical margin and you are unable to get satisfactory screening samples from that lady, then repeat excision is mandated to get clear margins. If you're over the age of 50, with potential deep and lateral endocervical involvement by high-grade CIN, you should have levels, and the end block should be turned to allow a definitive statement about the adequacy of excision at these margins. So for this document, we have offered 2 different ways of trimming. So for under 50, it's the usual way we would have trimmed the loop with the end blocks embedded. You can put them either way you like. But next slide, please. For the over 50s, we are suggesting that you do perpendicular slices on the end plane so you can more clearly establish what the deep margin status is. And while not entirely in alignment with the screening program's statement, it does allow you to further examine the margin, which comes into line with what the screening statement has said. Again, although not explicitly stated in the thing, there is a good link to the BAGP guidance. P16 should only be done in certain circumstances when there may be the morphological differences between a pre-cancer and a mimic. If you're diagnosing CIN2 or you're using it as a tool when there's a professional disagreement of interpretation for a lesion. So those are the 3 main reasons you should use P16. Next slide. And it should not be used for CIN1 or CIN3 or negative biopsies as a routine. Next slide. And just to highlight that P16 in squamous lesions needs to be continuous. It needs to involve the lower third and extend upwards and at least 6 cells, but it is acknowledged that it's not exact science and a bit of an arbitrary measurement, and you shouldn't use the term positive in your report, you should use block-like. And in the glandular lesion, use slightly different way of describing it. It's usually diffuse staining, and it is positive in nuclear and cytoplasm, but may just be nuclear, and it should be reported as the presence or absence of abnormal diffuse positivity, not block-like in the glandular epithelium. Thanks.
Thank you very much. That's a very quick run through some quite a wide range of specimens there. So thank you very much for that. We do have quite a few questions already coming in. There's a number of themes about them. The first is about adequacy, both of information in and sampling. So that might be a good place to start. So I think this one probably best go to Raji because it's about the endometrium. And someone was asking, you know, a lot of the time we get specimens that come in and say dysfunctional bleeding or PMB or something, and that's it. Yet when we're trying to interpret these things, there's a whole load of morphological features that benefit being correctly interpreted when we know what's going on with the patient. So what are your views on the adequacy of the information that we receive, and how stroppy should we be, I guess, about saying, look, give us decent information or we can't tell you what's going on with this patient?
Being quite long in the tooth reporting gynecological pathology here, I realized that these forms are filled in by people who don't know the clinical information most of the time. So what I generally do, and I'll tell you what I do, I write something. Say, for example, I will say, they have not mentioned norethisterone, they've not mentioned progesterone, but I know that the Royal College of Obstetricians and Gynecologists' first line of treatment for anyone who comes with abnormal vaginal bleeding to a GP is to have progesterone. Not mentioned on the form PNP. I will describe what is in the biopsy. I will then say, please corroborate with clinical history. If there is any discrepancy, please consider resampling. I rarely say the second one. I just say corroborate with clinical history. It's on them. But when there's a real problem in distinguishing whether there's hyperplasia or not hyperplasia, then I resort to immunohistochemistry, showing to my colleagues, and I do not go back to the clinician. No more clinical information is going to help me with that. I think there is a very, very, my opinion, flawed tendency to corroborate high BMI with hyperplasia. It isn't a corroboration, it's an explanation. So necessarily, if I'm worried it's hyperplasia and the woman is big, I don't call it hyperplasia because the woman has a BMI over 40. That is clinical corroboration. I would do Paxate, P10, beta-catenin, show it to my colleagues. If necessary, show it to other people via Teams or Zoom, and then issue a report. Okay, I hope that helps.
No, that's very helpful. Thank you. Well, we're just on the theme of adequacy. There's a question in about targeted cervical biopsies, and so when we're targeting the cervix, sometimes it might not contain the transition zone, but under those circumstances, the suggestion is that it should still be considered adequate because it's hit the target, and the target in these cases may not include the transition zone. Does that fit with the guidelines?
So it fits with certainly that's what the screening guidelines say. And if your biopsy, if your clinician will give you the history, again, it probably comes down to a history. You need to know that your clinician is, this is what they're aiming for. If they can let you know, we don't expect to see transformations only in this biopsy because it's very peripheral, then it's easier for you to agree. If there's no history, you can't be 100% sure, but as the guidance said, if it's a squamous lesion you're looking for, you need squamous epithelium in the background. If it's a glandular lesion you're looking for, you need glandular epithelium in the background. So it is going to be related to the clinical scenario.
Yeah, I think the context is everything, isn't it? And it's kind of difficult sometimes to make a rule for that because you'll know that from from your own dealings with the patient. Again, around adequacy, there's a question around the presence of endometrial biopsies that contain only cervix, and was that adequate? My feeling is that you can't really report any, if there's no endometrium in it, you can't report it. So if it's just cervix, you just say, this is cervix, I'm really sorry.
So we have two scenarios here. When you can actually identify the epithelium as cervical, then it's definitely inadequate. But sometimes you get strips of non-mucinous columnar epithelium. If they are from the endometrium, they usually have small amounts of clinging endometrial stroma at the base of these strips. So the way I report is non-mucinous columnar epithelium with small amounts of clinging endometrial stroma, superficial and scanty to assess architecture. However, there's no cytological atypia, and I do not report those as inadequate because I know they are from the endometrium. If I cannot spot those little cells and they're non-mucinous, I would say indeterminate origin, please repeat, and I would call that inadequate. So there is a small amount of titration that I do.
Okay, thank you. Chris, you mentioned in your bit of the talk about blocking LLETZs, and there is a question about the practicality of cruciates in these specimens in patients over 49. And the comment is that in their lab, they struggle to get nice full faces of conventional LLETZ blocks. So I'm not sure how well what the blocks would look like if we're trying to get full faces in cruciates. have you got any comments about that? And the question refers to the diagram that you presented.
I mean, it's definitely not easy, and it requires precise trimming and precise embedding and precise cutting. But ultimately, it will save you work further down the line trying to work out if a margin is positive or not. So that's why it is recommended, because it will make if it's done to a reasonable standard, it should make your life easier. But it's not necessarily an easy thing to do.
Okay, thank you. Just
Peter, can I just add?
Sorry, where are we?
It's me, Rupali. Hi.
Sorry, Rupali.
Just to add to that, Bruce's reply as well. Sometimes it helps when you take that last section a little bit thicker than the other sections, because then the cruciates become slightly more, kind of visible for the lab staff to embed correctly. Because if you continue to take thinner sections when embedding, even if with the best of the BMSs, the tissue is so tiny that it flips and flops when they're trying to cut it. So my experience is the last slices are usually kept thicker if you want to cruciate them. And that way the staff is able to identify the wedge of all these, all the cruciates. It works. It certainly works with the thicker last slices.
And the presence of some ink will help as well.
Peter, may I add as well? The red ink and the yellow ink that is prescribed in the guidance actually does help. And I think it does work. I mean, we had the same, we never used to do that before. I know some places in London, especially Barts, have always done that. And I used to have a lot of trepidation about it, but it works with the colors and with a little bit of gentle handling of the staff, and what Rupali said, slightly thicker the end ones, it does work.
These are very helpful comments, because they're difficult things, particularly the quality of specimen that we quite often get from LLETCs is relatively poor, and they sometimes quite often are fragmented, and it's very difficult to handle these appropriately. So your guidelines, your guidance is really useful. Thank you. Just again, talking about it again, this is very practical stuff, and it's about cervical biopsies. And somebody's asking about the number of levels that we should use on cervical biopsies. I guess the answer to that is always well enough, but we don't. How do we determine what enough is? And I guess you never want to leave the diagnosis in the block, but what would you consider to be reasonable? I mean, this person says, I regularly request three extra levels, and I do that too quite often, particularly when the specimen it's not that well presented. There's epithelium that's flaking off the edges, and you think, gosh, is that squamous epithelium attached? Is it twisted? How many levels do you do before you're satisfied, do you think, that what you've got is going to give you the answer?
Oh, we're hoping that 3 is the answer, because in this time when there's unprecedented pressure on the laboratory as well as the pathologists in doing things, if the slide can come to your desk in a state that you can make a diagnosis, that is what we're aiming for. It's not effective to do 6 levels on every cervix, because we get a lot of cervix biopsies using up a lot of lab time that shouldn't be benefiting you particularly much. So I think you need to maybe do an audit and look at the reasons why you're asking for more levels. Is it an embedding issue rather, or a cutting issue, rather a laboratory process rather than an inadequacy on your ability to actually make the diagnosis? So I think all you can do is really audit it, try and get to the bottom of why you need to do levels all the time on cervix biopsies. But there will be a subset of cervix biopsies where whatever the lesion is not quite visible on your initial 3 levels, and you will need some deeper levels. But the rationale behind it is to not overload the laboratories and do unnecessary work that is not actually benefiting anyone.
Yeah, okay, that's helpful, thank you. There's a question which it just asks very simply, will the SEC FIM protocol now need to be followed in all circumstances, given these current guidelines? I don't know who would want to answer that question.
So that comes under my remit.
Thanks,
so
Jason.
I might not have been clear. That's only for risk reducing prophylactic salpingo-oophorectomy specimens for patients, particularly those with BRCA mutations or other inherited or familial cancers. I think there was another question asking about
there is another question which is similar. It's about how we approach the sampling. Do we sample the entire ovary and fallopian tube when we have prophylactic resections from patients with breast cancer, presumably associated with the BRCA mutation?
Yeah, I think it depends. Are they associated with a BRCA mutation or not? And if the reason is a risk-reducing procedure for someone with a known BRCA mutation, then yes, you should be sampling the entire ovary and the entire fallopian tubes.
Okay, that's helpful. Thank you. So there's a question here which is perhaps more thought-provoking than practical, than immediately practical. So what it's about is HPV vaccination and how that has affected what we see clinically. So I'll just read it to you because it says HPV vaccination has changed the HPV profile of high-grade CIN so that CIN2 has a less high-grade PV profile. This has implications for management, particularly for conservative management. And monitoring of the HPV profile is an important aspect of HPV immunization surveillance, and therefore how it separates the identification of CIN2 from CIN3, and how that separate identification is still necessary in order to correlate HPV profile with clinical behavior and management. So how would you respond to that statement?
I would say HPV vaccination is going to change the playing field. And in theory, we're going to see less and less of these high-grade lesions. It's going to probably have a bigger impact on cervical screening than it will on histology because they're going to struggle to see abnormal smears. So it definitely will have an impact, and it will become a less frequent finding. I mean, it all depends, the rest of the world doesn't quite view CIN the way we view CIN anyway. So CIN2 is always going to be a controversial entity, and I think it will remain as such.
Okay, thank you. I think it's an interesting thing because it's something that in other branches of pathology we spend a lot of time looking at the effects of the modifications of disease by the treatment that we've given the patient subsequent to our diagnoses and how that alters the features that we're looking at. So it's interesting that it's occurring here as well. I think that it comes back, there was a point you actually made, Bruce, which I wonder if you could perhaps clarify for me, if nobody else, was around the use of P16 staining it in CIN2 and the recommendation we should use it for CIN2 but not for 1 and 3. And I didn't understand what the rationale was there. I wonder if you could explain that again for me, please.
CIN2 is the point where sort of intervention happens. So treatment's different between CIN1 and CIN2.
Sure.
For CIN1, P16 not going to help you because CIN1 can be high-grade HPV positive. So it's actually the morphology that's going to decide whether it's CIN1 or CIN2. It's not your P16 that's going to decide it. And in general, for CIN3, it's usually an easy diagnosis that's highly reproducible. And again, the P16, they will be positive, but it's not really going to change your diagnosis. So I think the feeling is that in CIN3, it's not really necessary because you make that diagnosis anyway. And in CIN1, you get into trouble if you do P16. It makes it much more difficult, and you tend to upgrade it then because you're saying, well, it's P16 positive, I'm going to call it CIN2 rather. So to avoid that situation, it's better you don't do the P16.
I think it's really interesting actually to get an expert saying don't do the ICC because it'll just make matters worse. I think that's something in the guidance perhaps we should have more frequently, Cynthia and Maria, going forward, because I think it's good advice, because if you turn the stone you'll find the creepy crawlies and then you've got to explain them, and I think it's sensible, particularly when it's just going to make matters more confusing at the end of the day. So thanks for that one. Again, we continue with margins and how we handle them. So we've got a question is about grading of CIN at involved margins And is it helpful? Are we able to differentiate high-grade and low-grade disease? And if we do so, does it make any difference whether it's high-grade or low-grade on a margin? Again, what is the margin is often tricky because of heat artifact and fragmentation at the margins. So again, how would we best handle that?
Well, I think as you have stated that, margins are a little bit euphemistic, but if you see something at the margin, you need to call it, whether it's high grade or low grade. And I would keep it probably down to local MDT on how you manage your margins. We might ignore CIN1 at the margin because you're having a test of cure and other procedures after the loop anyway. But if it's high graded an endocervical margin in an elderly patient who's had multiple loops, and you're not going to be able to follow them up with smears or colposcopy, then it's much better to have a repeat excision rather. So I think, again, it's pretty much scenario based, but if the margin is involved, you need to say that the margin is involved. And if you can distinguish between low grade and high grade at that margin, I would certainly put that in my report.
Okay, that's helpful. Thank you. Come back to, again, adequacy of cervical biopsies. And the question is an adequate biopsy for histopathology reporting, or should it include the transformation zone? We've already discussed that. The answer is probably yes, except in specific circumstances. In the NHS CSP histology guidance, it's clear that a cervical biopsy is not inadequate if it only includes ectocervical tissue when it's a targeted biopsy. So I think we've kind of handled that one already, and so I don't know that we need to address that specifically unless there's anything else that any of you think we should be adding to it.
I would be giving the same answer I gave earlier.
That's fine.
Be in context, and if your clinician tells you you're not going to see transformation zone in this, you're not going to see transformation zone. But I would still in the report say I haven't seen transformation zone.
Of course.
I wouldn't call it inadequate, but I would mention it.
Yeah, that's helpful. Thank you. Pinias.
Yeah, so I agree with Bruce. Just to add to that, so the screening program recommends that you can put in a caveat to say the biopsy may not be representative. So he said there's no TZ to describe what is in there, but because it doesn't have TZ, it may not be representative. So you put that in the report.
Thank you. We're still on cervix. So there's a question here about the assessment of depth in LLETZs. And again, most people use the top of the cone to the base and to measure thickness or depth perpendicular to the surface epithelium and the base of the tissue section. So depending on which way you do it, you get different measurements of thickness. So which would you recommend is better, particularly when we're talking about looking for a depth of 7 millimeters? Pinias, is your hand a legacy, or you want to address this question?
Sorry, that's a legacy hand. Sorry.
Oh, come on, you can address it, Pinias. That's fine.
I've lowered it now.
I think, I don't think it's an exact science, the measurement of things. I will tend to give the biggest measurement I can get in my loop. I will look at the macroscopic description. I'll look at my slide, and I often measure it on my slide as well, because I think sometimes at trimming, there is an underestimation of the depth of the loop, and it is an important factor or measurement that is used to police the colposcopists. So I think we need to get it as accurate as possible, but I haven't seen any definite guidance on exactly how to measure that. I don't know if any of the other panelists have, but I will always take the biggest measurement I can get from the epithelium downwards.
Okay, thanks very much. Just change the subject slightly for a minute. There's a couple of questions which have a more kind of biological look to them. One's about MMR and the other one is about subclonal loss. So the question is, can you explain for MMR, is there a 10% cutoff, for example, for proficient staining? Or how do we determine what staining is proficient when we're staining for MMR?
Shall I take this one and ask for others to chip in? I don't think there's a cutoff for proficient staining. It should be the two problems with proficient staining that you have is it's usually better in well-fixed endometrial biopsy samples than in hysterectomy specimens. And in the hysterectomy specimen, I suspect that the person's asking about hysterectomy specimen because in the endometrial biopsy, there's no cutoff. It has to be all over. And sort of slightly correlated, there's another question below with subclonal loss, experience with subclonal loss. One of the commonest examples of commonest explanations for true subclonal loss is polymutation. Polymutation can result in subclonal loss. If there is a subclonal loss, otherwise, recent literature has shown that it has no real impact, subclonal loss. And I'd like the others to chip in. It's not specifically addressed in the tissue pathway, but we have the BAGP document and there's a lot of work going on, especially Rupali, and I've been working on the endometrial data set. So perhaps Rupali would like to add as well, Peter.
Yeah, please do.
Hi. Just to say about the percentage about trying to qualify whether it works. This all started with the colorectal specimens, really. When they were talking about the percentage of threshold where you start calling it. In the endometrial, if you read the literature, it goes from anything from 1% up to 10%. So the consensus really is that you really need to have kind of diffuse staining. Apart from obviously, like Raji said, fixation artifact is a real thing in the endometrium. So you have to be aware of that. And the BAGP document states about how do you say if tissue is fixed and it's a true, loss with stromal cells, etc. Again, subclonal, usually you see in MSH6 as a subclonal, loss, which we've seen quite commonly together with MLH1 and PMS2 loss. Again, as Raji said, these are supposed to be non-consequential. They don't really need, clinical genetic referral. They're supposed to be somatic rather than any genetic connotation. So they might be poly. Majority of them could be poly related as well. You would send them for poly because of the MLH1 and PMS2 loss anyway. So they would get poly.
Okay, thank you. There's actually probably more questions than we're going to be able to get through on this in the time available. A lot of it is around about handling of LLETZs and cervical specimens generally. I think the conversation has largely been around a cervical and LLETZ, but there is a question about the ovary here. And so it's about what do you think about sampling an entire tube and ovary in endometrial carcinoma specimens where you've got macroscopically normal tubes and ovaries? Does this come into this is too much work, or is there diagnostic merit in it?
I'll hand over in a minute to Raji and Rupali, working on the endometrial cancer dataset. I still currently use the ISGIP guidance, I think from 2019, and they recommend that in high-grade endometrial cancer, you sample the entire fimbrial end. So in high-grade endometrial cancer, you sample the entire fallopian tubes and the entire ovaries. And they recommend that in low-grade endometrial cancer, you take at least 2 TSs of the ovaries and the fimbrial ends of the tubes. But I don't know, Rupali or Raji, whether you have an update on that.
Yeah, I think we've quoted that in the data set as well to say that some people do choose. We are not standardly recommending to take entire tubes and ovaries in all cases of endometrial cancer. That's certainly not coming in the data set. But some centers we are aware, and one of the authors on the data set does do that as well as all tubes and ovaries in high-grade tumors, following that guideline, Jason. We at UCH certainly did tubes and ovaries in all cases of endometrial cancer, but reading more and more literature, we've coming down to say that we won't be sampling entire tubes and ovaries. So you don't really need it if it's not high grade, and that will be coming up in the data set.
Okay, thank you. Continuing in the idea of a prognosis, again, there's a question about the value or the potential value of P53 mutations in endometrial cancer. What's their importance? How do we best interpret them? That would probably be you. You want to answer that, Raji, or?
Yep. We standardly request P53, MMR, and estrogen receptor staining on all endometrial cancer, and that's the recommendation. We're wandering off a bit from the guidance tissue pathway right now, and we're going into the realm of an endometrial data set, which is under preparation right now. But the importance of P53 is mutated and almost considered to be a driver mutation in case of uterine serous carcinomas. And where Jason and Rupali were talking about sampling the fimbrial end of the fallopian tubes is to make sure that it is the uterus cancer that you're seeing, which is a serous carcinoma, is not a drop deposit from a primary fallopian tube carcinoma. And if I were to a little bit expand on that, cervical carcinomas, cervical serous carcinoma is no longer considered an entity and almost always considered to be a drop deposit of a fallopian tubal carcinoma. So if you had a serous carcinoma of the cervix, you're more important for you to get back and sample the rest of the fallopian tube and the ovary to make sure you aren't missing an ovarian carcinoma, which is dropped to the cervix. And I think the reason for it is management. They're managed differently if they're uterine serous versus primary tubal serous. And management, one of the things is HRD testing and giving PARP inhibitors to the patient. So that's the importance of P53. But P53 can be mutated in about 50% of grade 3 endometrioid carcinomas and can be also positive. POTIC 3 showed that a minority of clear cell carcinomas of the endometrium can also be P53 mutated. So it doesn't point to the diagnosis unless the morphology is correct. Rupali, anything on that one?
Yeah.
But I was busy typing an answer just to, because there's so many questions. Sorry, Raji, I missed that completely.
It's all right. Don't worry. We'll just carry on, and because we're close to time. I've just got time for one final, really quite quick question, which is more philosophical, and it's looking in the crystal ball and saying, okay, we've got CIN1, CIN2 and 3, and we've got high and low grade SIL. What's that going to look like in 5 years? Are we still going to be using both of those terms, or will we have gone one way, do you think?
That's a difficult cultural question to answer.
Yeah, there you go.
I think it's more cultural than anything else, because in reality we have gone that way, but the UK hasn't quite gone the whole hog. It may well be that in the future we'll be seeing less of this disease, and maybe it will stratify into a high and a low rather than anything else. Unless we find some funny molecule that will distinguish something else in the middle, which could also happen.
Yeah, that's always the issue, isn't it? Well, we're out of time, really, because we need to conclude this within the next couple of minutes. So it's up to me to say thank you. And that's very easy. So thank you all, the panel, for such an interesting presentation. Raji, Bruce, Jason, Pinias, and Rupali for coming and answering the questions. So thank you all for your work in producing the tissue pathway in the first place, and for taking the time to come and talk to us all today. We should tell you that the webinar will be available on the college website in a few days once it's been edited, and thereafter it will be available to college fellows, members and associates in due course, along with the rest of it. And again, your feedback around these webinars is useful in how we go forward, both in terms of the production of new guidelines and the continuing webinar series. Finally, just before I finish, could I just give my thanks to the RC Path team, particularly Tanchel, who's put a lot of work into this webinar, Cynthia, Reese, Maria, who contribute to all of this. I hope you have a very nice afternoon wherever you are, that the wind doesn't blow you off the planet, and wish you all the best and look forward to seeing you at the next college webinar. Thank you very much. Good afternoon.